That was fantastic. Thank you. It's really, it's definitely a paradigm change and not, not straightforward. All right. Next, we have another challenge, talk, from Dr. Megan Tenney, who got stuck. Did I say your last name correctly? Tenney, who, was out, went to Fairbanks to see the Northern Lights and then, had an Alaska experience by getting stuck there. And made it in early this morning. So thank you so much, Dr. Tenney, for coming. We're super happy that you're here. She is works in Atlanta, Georgia, at Northside Hospital, and is going to speak to us about another paradox in gynecologic cancer care, that our treatment understanding of is evolving, which is aggressive endometrial cancers and low-grade ovarian cancers. So welcome.
Thank you. This my clicker. All right. So let's see.
There you go. And that's what's showing.
Okay, there we go. Excellent. Thank you, Dr. Hope, and everybody. You gave me a very challenging task to talk about all of this in 25 minutes. So I might not get through all my slides. I'm going to try. Luckily, I was going to spend the beginning talking about what Dr. Marcus just did. So I'm going to skip the beginning of my talk and get straight to the nuts and bolts. These are my disclosures, which aren't really any, except thanks to Amanda Nichols-Fader, who did provide me with some of these slides. And she's the current rare tumor guru who you will see has actually written all the protocols I'm about to talk about. So these are my objectives, which I'm going to skip this right now. So I hid those slides. And we already talked about kind of the troubling trends that we're seeing in endometrial cancer, both incidence and death over the past few years with it now. I wasn't sure, but Dr. Hardesty this morning just told us that it's actually overtaken ovarian cancer now as far as death. So that is quite unfortunate. We think it's likely multifactorial. A lot of it is due to increase in obesity and higher BMIs. But there's also a large percentage of racial disparity that's going on, as well as an aging population. And so in the interest of time, I'm not going to go through these graphs in specific, but you have access to the slides and you can see where the data is going. So skipping now to the high-risk histologies that we were just talking about in endometrial cancer, which are these historic, aggressive, difficult to treat cancers. We have uterine serous cancer, which comprises a very small subset of all endometrial cancers, however, a disproportionate number of deaths. There is a high percentage of advanced stage disease at diagnosis, and a fairly poor 5-year survival compared to our lower risk grade 1, grade 2 endometrioid histologies that are now the non-aggressive subtypes in our new staging system. Historically, these have a low response to chemotherapy, both in the upfront setting and in the recurrent setting. And as we just learned, they seem to be molecularly distinct from our other endometrioid cancers. But this also is potentially a good thing because we have mutations we can target and new drugs coming down the pipeline every day that target these specific mutations. So I will go through the two main mutations, which are P53 and HER2, and talk about some of the studies and the drugs that we have to target those to help with our treatment. So HER2, previously known as HER2/neu, or sometimes you'll see it as ERBB2. It was first identified in our breast cancer patients and was amplified and found to be a predictor of actually poor survival and metastatic disease. It's now been identified in numerous other cancer types, including 3 of our GYN cancers, uterine, ovarian, and cervical. So HER2 is involved in cell signaling and cell growth, eventually survival and proliferation. And so disrupting the cycle and manipulating HER2 potentially can help in cancer patients. And so we know that in uterine serous carcinomas, there's 14 to 80% overexpress HER2. Those numbers are really broad because these studies are really small, and this is very kind of understudied patient population. And so depending on the case series, you know, with really small numbers, they can be wide, but it's generally accepted that it is overexpressed. And so going on that little bit of information, as well as what we know from other disease sites, mainly breast, Dr. Fader and her colleagues at Johns Hopkins did a phase 2 study of serous carcinoma patients that overexpressed HER2, and these were both previously untreated, advanced stage, or recurrent who had previously been treated. These patients were randomized 1-to-1 to either receive standard of care carboplatin and paclitaxel versus carboplatin paclitaxel with the addition of trastuzumab, which is a monoclonal antibody that targets HER2. And so these women were randomized, and what we saw was both an improvement in progression-free survival for the advanced stage upfront patient populations as well as recurrent disease. So what we see is, it's really hard to see, but this is, I think in A, I can't even read which one this is. A is the progression-free survival for all patients. B is the advanced disease. Whoop. And C is the recurrence. And so then they further pulled out the advanced stage upfront patients, but excluding 3A and 3B. So this is like the worst prognosis patient population. So stage 3C and stage 4. And there was still an improvement in progression-free and overall survival with the addition of trastuzumab to standard of care carboplatin and paclitaxel. And so this essentially set the stage for a change in guidelines, where this is now the preferred regimen for women with HER2 positive advanced or recurrent serous carcinoma per the NCCN guidelines. And so that's what we have. This is just based on one phase 2 study with not a lot of patients. And so what are we going to do now? Now, again, copying from breast cancer, which we've already talked about today, we do a lot in GYN cancers, is dual inhibition with targeting HER2 and HER3, so using trastuzumab and pertuzumab. So there was a small study of endometrial cancer patients, 28 patients, who got dual therapy. This is part of a bigger basket trial called the TAPER trial. And this showed a disease control rate of 37% and progression-free survival of 16 weeks and overall survival of 61 weeks, which in an extremely heavily pre-treated population was promising. And so this is likely moving forward. And then what about early stage disease? What I've just been talking about is advanced, recurrent, poor prognosis patients. So Dr. Fader, with the help of Dr. Erickson, looked at early stage uterine serous carcinomas and found a very high percentage, a decent amount, over 25%, expressed HER2. And so putting all of what we just talked about together, the current study is a 3-arm study of newly diagnosed all patients, stage 1 to stage 4B, uterine serous carcinomas and carcinosarcomas, which is another one of the aggressive histologies that expresses HER2. Looking at the addition of either trastuzumab alone or trastuzumab and pertuzumab to standard carbo and paclitaxel. This is currently enrolling. It has not enrolled a lot of people. But we look forward to getting this answer both for early stage disease and for combination dual inhibition. So antibody drug conjugates against HER2. I'm not going to talk about that now because I'm talking about that this afternoon. So moving on, targeting P53. That was the other mutation that the serous cancers have, and a bunch of our other cancers. We talked about it for ovarian earlier. So WEE1 inhibitors are a category of drug that can target P53. And for the interest of time, and because I'm not super smart with all of this crazy molecular cell cycle interaction stuff, but WEE1 regulates the cell cycle, and if you inhibit it, it kind of forces the cells to go through mitosis without the ability to be able to do DNA repair, so then it leads to subsequent cell death. And so the drug that is being currently studied is azenosertib, which I think I said right. So a very early phase 1 study, this first study 001, has been presented. There were only 11 patients, but it showed a disease control rate of 91%. And disease control rate is those who had either stable disease or some sort of response to treatment. And 27% had an objective response rate. So that was good enough to move this drug forward. And so the current GOG study that is going on, that was recently activated. It went through a lot of changes and resubmissions to the protocol, I know, at least at my institution, but we finally just got this open. So this is looking at azenosertib in recurrent or persistent serous carcinomas that have prior platinum-based chemo. Patients had to have received immunotherapy if they were eligible, and HER2 positive patients had to have received a prior HER2 targeted agent in order to be able to go on this. So looking forward to figuring out if WEE1 inhibition is going to be positive for uterine serous carcinoma. And then finally, the last current target that, at least at my institution, we have studies looking at is MDM2, which is an oncoprotein that also is involved with P53. And so it attaches to P53, which then leads to degradation of P53. And so then you don't have the tumor suppression and the cells can grow uncontrolled. And so by inhibiting MDM2, you stop that P53 degradation. And so then the cell can do DNA repair and subsequently, not grow uncontrolled. And so this is the current study that's open. We just opened this at our institution, like I think 1 or 2 weeks ago. Navtemadlin is an MDM2 inhibitor. And so that is also being looked at. So that's serous carcinoma from 10,000 feet. Next, looking at carcinosarcomas and clear cell carcinomas, which are 2 of the other aggressive histologies. They are much less studied, so I don't really have that much to say about them many times, and usually they're excluded from trials because they are so rare and such a poor prognosis, so we have very limited data. So carcinosarcomas, less than 5% of all endometrial cancers. They used to be treated as sarcomas, but as we've learned more about them, we actually think they're carcinomas that then just go haywire and de-differentiate into a sarcomatous component. So now they're treated more as carcinomas. Recently, carboplatin and paclitaxel became the standard of care after the publication of a big GOG study a few years back. But despite that, they still have a very poor prognosis and poor survival. So I briefly mentioned that carcinosarcomas that are HER2 positive are eligible to enroll on the GOG study right now, that 3-arm trial. There was also specifically a very small trial that was done in uterine carcinosarcomas that were HER2 positive. This was looking at both HER2 high and HER2 low patients, so not just the super positive on immunohistochemistry. They allowed low positive patients, looking at the antibody drug conjugate trastuzumab deruxtecan or TDXT. And it showed, you can see those waterfall plots. Dr. Hardesty mentioned earlier the plot that she saw where it was just everything was on the down. So below the line means a decrease in tumor size. So you can see here there was a fairly good response rate, both in the high group, which is on the top, and the low group, which is on the bottom. So even HER2 low positive patients tended to respond to this. Immunotherapies, we've talked about the RUBY and the GY18 trials multiple times today. The trouble with those is that carcinosarcomas were excluded from GY18, and there were only 44 on the RUBY trial. The other trial looking at immunotherapy, which is KEYNOTE-775, which is lenvatinib, which is an oral kind of anti-angiogenic drug, along with pembrolizumab, excluded carcinosarcomas as well. So we have only 44 patients who've been treated on our 3 largest immunotherapy trials for carcinosarcoma. So leading to clear cell carcinomas, which also are excluded from just about everything. They weren't even in the TCGA data, so we don't know anything from TCGA about clear cell carcinomas. We do know that they often have some sort of defect in ARID1A, which is a tumor suppressant gene. And so we can potentially use that to our benefit and use drugs that potentially target that. One of those, specifically ATR, when you inhibit ATR in ARID1A deficient cells, again, a very complex mechanism, but then that leads to cell death. So in ARID1A deficient tumors, if we can target ATR potentially. So this just summarizes some of the other major trials where no clear cell carcinoma patients were allowed. Different to carcinosarcomas, they were allowed on all of the major immunotherapy trials. And so there were 9 whole patients on RUBY, 37 on GY18, and 47 in KEYNOTE. But they were allowed on all those trials. Current clear cell trials going on. There's a 3-arm trial that's not yet open. I believe it's not open in this country. It's going to be in Europe. Looking at dostarlimab alone or with bevacizumab versus non-platinum chemo in recurrent clear cell cancers. And then the ATARI trial, which is looking at ATR inhibition, which I just talked about. That actually has been presented in very preliminary form just at the end of last year at ESMO. And it did show that there was some activity of the ATR inhibitor ceralasertib in endometrial cancer. So more to come on that later. We don't know enough yet about how many clear cell patients were on there. And so this is just a summary of the targeted agents that are approved in endometrial cancers. It's very small, and everybody knows how to look at the NCCN guidelines, but the specifics are, you know, that trastuzumab in combination with carbotaxol is approved for upfront, advanced, and recurrent HER2 positive carcinosarcomas and serous cancers. Immunotherapy combination with carbotaxol, pembrolizumab for anyone but carcinosarcomas. It specifically says no carcinosarcomas because they weren't on the trial. So per NCCN guidelines, you can only use dostarlimab for carcinosarcomas. I know many people use pembrolizumab, but this is the most recent, just updated little asterisk footnote that says you're only supposed to use dostarlimab. So Now to low-grade ovarian cancers, the complete opposite. Thanks, Joni. How am I doing on time? So this is actually a little bit more straightforward because I'm only really going to be talking about one type. There's lots of other rare ovarian cancers, but I'm focusing on low-grade ovarian cancers because it's what we know the most about and what we have the most treatment options for now with what we're learning. So low-grade serous ovarian cancers is a rare subtype. Only a few % of all epithelial ovarian cancers and 10% or less of all serous carcinomas. We think it's a completely distinct entity now from high-grade serous ovarian cancers. And these patients tend to be more young, have better survival, a more kind of long, indolent clinical course. But they are diagnosed similarly at advanced stages to our high-grade serous ovarian cancers. And molecularly, we think there's kind of two origins of low-grade versus high-grade serous cancers. Low-grade cancers, we think, arise either de novo or from a serous borderline cancer, whereas the high-grade carcinomas, we think, arise from precursor lesions likely in the fallopian tube. The molecular mutations are completely different. And again, like with the endometrial cancers, we use those mutations to target in our current treatment options. And then hormone receptor positivity, almost unanimously, low-grade serous carcinomas have either estrogen or progesterone receptor positivity, mostly estrogen. High-grade carcinomas don't. And low-grade carcinomas have very poor responses to chemotherapy, both upfront and in recurrent setting, which makes sense because they're slow growing and chemotherapy likes things that are growing fast. And I went backwards. And so chemotherapy just doesn't work in these cancers. So I'm gonna, so we know that the younger someone is when they're diagnosed, the worse they do. And residual disease at the end of treatment, the worse they do. And so especially these youngest of young patients, so we have these disproportionate number of young women dying from low-grade ovarian cancers. And so what can we do? What is the problem? So like I mentioned, chemo-resistant presents at advanced stage. So if our chemo doesn't work, what are we going to do in order to stop these women from recurring and succumbing to their disease? So in the primary setting, surgical debulking is the mainstay. There was an ancillary study of one of the major ovarian cancer trials done by Dr. Fader and others who looked at grade 1 ovarian cancer patients on this study. They used grade 1 as a surrogate for what we now call low grade, because just like endometrial cancer, ovarian cancer has kind of gone from grade 1, 2, 3 to now just low and high grade. And so they found that progression-free and overall survival was significantly improved with microscopic disease only. And the more disease you had, the worse your prognosis was. And after a multivariate analysis, the only thing that was statistically associated with survival was residual disease. And so this should be the mainstay. But now after surgery, what do we do? I mentioned that hormonal therapy, or that these cancers were hormone positive. So what can we do to manipulate the HPA axis or our peripheral conversion of testosterone to estrogen? And so there's multiple places in this whole pathway where you can interfere, differences in if someone is pre or postmenopausal and if it's going to act centrally or peripherally or even in the cellular level. And so looking at that, two major studies looked at using hormonal therapy in the upfront setting. And so the MD Anderson study, patients got chemotherapy followed by hormonal maintenance. And in the Hopkins study, patients did not get chemotherapy at all, and they only got hormonal therapy. So that's the kind of difference between those two. But both studies showed that well, in MD Anderson, the patients who got hormones as opposed to just chemo and then nothing had a drastically improved progression-free survival, 26 versus 65 months. And in this, letrozole was the most common hormone used. In Hopkins, patients only got letrozole afterwards for the most part, and then it was continued indefinitely. And the progression-free and overall survival rates were very good, and the median hasn't even been reached yet, at least at the time of this, and then the original and then updated 2 year later survival still has not been reached. And so after these two studies, the NCCN added the option of chemotherapy followed by hormone therapy versus hormone therapy alone for the upfront treatment of low-grade serous ovarian carcinoma. Now, this was based just on those two small single institution studies. And so now, as we always hopefully do, we do a confirmatory trial. So this is the international trial that's going on right now. Chemotherapy followed by maintenance letrozole versus letrozole alone in upfront primary low-grade serous carcinoma. It has accrued 306 of 450 patients, which last I had seen was only 100. So I think accrual has really taken off recently. So it's been open for a while. It was slow to start, but hopefully it will end soon. With low-grade cancers and it being so indolent, it's going to be many years until we actually get the answer to this. But this should hopefully answer our question once and for all. And so finally, for recurrent disease of low-grade ovarian cancers, what do? Well, we use hormones in the upfront setting. So obviously, we're looking at hormones in the recurrent disease. There are multiple hormone single agents listed in the NCCN guidelines for the treatment of recurrent low-grade serous ovarian cancer. This was a recent update where they broke it out even more specific to recurrent low grade and upfront low grade. And so there's a nice list there. To the right are just some of the studies that have been done showing that there are decent response rates and stable disease rates among various studies and various hormones in the recurrent setting. But still, they're not that great. So what can we do? We can add something to hormones, just like we always like to add things on in cancer. Well, one thing doesn't work, let's add two, let's add three. Or now with cervix cancer, let's add four. So GOG 3026 was a late-breaking abstract in SGO last year, looking at the addition of ribociclib, which is a CDK4/6 inhibitor, to letrozole. This combination in breast cancer has shown to be highly effective and have very good survival and response rates in hormone positive breast cancers, recurrent, who have been heavily pretreated. And so again, complex cell cycle interactions between inhibiting the two, but it biologically makes sense. And so we looked at this combination where patients got oral ribociclib. It's given 3 weeks on, 1 week off, and then letrozole daily. So this is an appealing thing because it's 2 oral medications. So patients can be traveling, they can live far away. I have a patient who lives out of state on this study. And with COVID and telemed, we do everything virtual now. It showed a 33% response rate. All of these were partial responses, and a clinical benefit rate of almost 80%, which includes those with stable disease and responses. And adverse events were manageable and as expected, so there were no new safety signals. I mean, this is a combination that's FDA approved for breast cancer, so it's very commonly used. And here's the little waterfall plot. The oranges are stable disease and the blue are the responses. So you can see, again, the vast majority of patients had some benefit. This is not yet in NCCN guidelines, and I have yet to successfully get an insurance company to approve it, even with appeals and even being an author on the paper that I send them, and they don't approve it. So hopefully it will be soon. And then finally, the other category of drug that's used in low-grade cancers takes advantage of their mutations in BRAF and in the MAP kinase pathway. And so MEK inhibitors are one of these drugs. Two major studies were done within the past 5 years. The first, the Milo study, actually was stopped early due to futility. And it showed no improvement in progression-free survival and not great response rates, but good stable disease. But anyways, it was stopped for futility. It was published though, and in the post hoc analysis, they did identify that those who had a KRAS mutation did tend to have a higher response. So this didn't get rid of MEK inhibitors, just needed to be maybe a different one. So trametinib, which the GOG study was done, recently published, is a little bit different than it inhibits a couple different things. And so this was done versus standard of care. Standard of care here included 3 types of chemotherapy, but also letrozole or tamoxifen. So it included hormones as a standard of care. And what we see is that on the top, that's trametinib versus just generic standard of care. And so it did show an improvement in progression-free survival with trametinib. And then the bottom is trametinib versus letrozole, which was a pre-specified subset analysis that they did because letrozole is the most common hormone that everybody uses. And there was continued progression-free survival benefit. And so after this, MEK inhibitor and trametinib kind of became likely the standard of care before hormones in the recurrent low-grade ovarian setting. And then finally, I think I'm getting ready to the end. This was the MATCH study, an NCI MATCH, which is like a basket study. This was all patients with a BRAF V600E mutation, which melanoma was kind of the first cancer where we saw these mutations, but low-grade serous ovarian cancers do have it. And there were, I think, 29 patients who got this combination of a BRAF inhibitor and a MEK inhibitor. So again, adding things together to kind of use them to our advantage. And it showed a very good response rate, and in the Kaplan-Meier curves, good progression-free and overall survival. So after this study, the FDA granted approval to this combination in any solid tumor that has a BRAF V600E mutation. And so it is now in the NCCN guidelines for essentially all of our cancers if they have this mutation. Here I just put the low-grade NCCN guidelines I was talking about, where it specifically, kind of lists the hormones that it recommends. And then there are some other trials looking at other combinations, but I don't have time to go through all of it. This is just a few of the ones that are being done right now, multiple different combinations. Only one on here actually has chemotherapy. Everything else are molecularly targeted agents. And that is it. So we need to treat these women completely different based on.
Wow. Hey, woo! That's Mike's way.
On